Assalamu alaikum. It's a journey of mistakes where I will discuss my cardiology mistakes. Hope you enjoy it. Okay, start with this question. This 50-year-old man comes to me, comes to you with the complaint of left posterior calf pain. He comes with left posterior calf pain, and pain occurs most often with walking. In the course of his job as a postal carrier, and but he occasionally has cramps at rest. He has hypertension, diabetes, cardiac stress testing is negative. He's a smoker. This is very vital. Smoker, and his father suddenly dies at the age of 60. And his mother had a stroke. Most important, popliteal dorsalis, arterial dorsalis pedis, and tibial pulses are palpable bilaterally. Echo ECG show normal sinus rhythm. HbA1c is high, most appropriate next. If somebody comes with a calf pain, then and he is a chronic smoker, do ankle brachial index. Why we are doing ankle brachial index? To look for peripheral arterial disease. And another thing in these question, they are talking about the claudication type of pain, like he occasionally has leg cramps at rest. So ankle brachial index is systolic blood pressure, systolic blood pressure of arteria dorsalis pedis or posterior tibial artery. Systolic blood pressure of arteria dorsalis pedis or posterior tibial artery divided by systolic blood pressure of the brachial artery. If it is less or equal zero point 0.9, diagnosis of the peripheral arterial disease. If it is zero point 0.9 to 1.3, it is normal. If it is more than 1.3, it suggests calcified and incompressible vessel. Other testing should be considered, but this is a unique test. Like patient comes to you in the outdoor and you can diagnose peripheral arterial disease. Okay, this patient has multiple risk factors like atherosclerosis, diabetes, hypertension, smoking, symptoms consistent with intermittent claudication, and he has complaints of the waist pain too. The next step in this management should be obtain physiologic testing of the ankle brachial index to confirm the presence of peripheral arterial disease as a cause of his symptom. ABPI is inexpensive and non-invasive vascular test to confirm the diagnosis of the peripheral arterial disease. Ankle brachial index point less than 0.90 is considered as peripheral arterial disease. Why we are not doing abdominal ultrasound? Age is 50. Abdominal ultrasound for abdominal aortic aneurysm should be men age 65 to 75 with a history of smoking. Why are not doing the arterial ultrasound of the lower extremity? Is another non-invasive modality for diagnosing of the PAD. However, it is less sensitive and specific. These arterial ultrasound is less sensitive and specific than the ankle brachial index for the initial diagnosis of the peripheral artery disease. It is generally performed in symptomatic patients with abnormal uh, ankle brachial index who are being considered for interventional procedure. So when the patient is on interventional procedure, we are thinking about the interventional procedure. That time we will do arterial ultrasound. Okay, other options are not that important. So AB high ankle brachial index, very high test. Next, now this 14-year-old boy is brought to the office. This 14-year-old boy is brought to the office um, for evaluation after his father experienced sudden cardiac death. The carotid pulse has a dual upstroke. Carotid pulse has a dual upstroke. there is there is a strong apical pulse and faint mid-systolic murmur best heard at the cardiac apex, and along the left sternal border. The lungs are clear. Which of the following young boy dual carotid has dual upstroke? There is a faint mid-systolic murmur at the cardiac apex, also along the left sternal border. Looks like HCM, hypertrophic cardiomyopathy. In HCM, I remember the HCM as Van, Valsalva, Valsalva, abrupt standing, and GTN, that means the nitroglycerin. We know that these three actually decreases the preload. These three actually decreases the preload, increase murmur intensity. Other S like SSP, sustained hand grip. First of all, squatting, sustained hand grip, squatting hand grip actually increases the preload, increases preload. Squatting hand grip and leg raising actually increases the preload, so decreasing murmur intensity. Okay, what happens in this question? In this question, there is they haven't talked about the murmur increase decrease, but we need to find out. So Valsalva, abrupt standing, nitroglycerin, these three decreases preload. I have already told you these three decreases preload and increases murmur intensity. And the SSP, sustained hand grip, squatting, and the P for passive leg raising. Sorry, passive leg raising increases preload, decreases murmur intensity. Passive leg raise, increase preload, decrease murmur intensity, decrease murmur intensity. So these are the things you need to remember for HCM. So if I'm looking at this box again, Valsalva Vans, Valsalva abrupt sting, and nitroglycerin decreases preload, increases murmur intensity, but SSP, squatting, sustained hand grip, and passive leg raising increases preload and increases afterload by the sustained hand grip, which will decrease the murmur intensity. And a passive leg raising, we know that these increases the left ventricular volume, and Valsalva abrupt standing and nitroglycerin decrease the left ventricular volume. So this patients and is further experience sustained cardiac death on hiking. So that is the thing in this question that I need to remember. Okay, these are the videos for These are the videos for hypertrophic cardiomyopathy.
Hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is characterized by enlargement of the interventricular septum. The enlarged septum restricts flow through the left ventricular outflow tract. Outflow obstruction varies with left ventricular volume. Standing causes blood to pool in the legs and reduces venous return to the heart. Left ventricular volume is decreased, which worsens the obstruction and accentuates the murmur. In severe cases, systolic anterior motion of the mitral valve leaflets may further exacerbate the outflow tract obstruction. Other maneuvers that decrease left ventricular volume, such as Valsalva strain phase, will also accentuate the murmur. Squatting increases afterload by compressing the vasculature and causes the pooled blood in the legs to mobilize. There is an increase in venous return to the heart. Left ventricular volume is increased, which lessens the obstruction and decreases the murmur. Supine leg raise and hand grip also increase left ventricular volume and decrease the murmur.
Okay, that's it. Next, so 57 where JVPs are not distended, ECG, normal sinus rhythm, appropriate management for this patient, 57-year-old woman. So he has not that type of risk factor like cardiac risk factor. So we need not to do any further testing. But in here, the most important thing is before doing a surgery, you need this revised cardiac risk index, cardiovascular risk for non-cardiac surgery, cardiovascular risk for non-cardiac surgery. So this 57-year-old woman comes to the office preoperative evaluation of the they come with the for evaluation of prior arthroscopic menis meniscectomy. Under general anesthesia, the patient can perform activities daily living. This is not that important. So he comes for preoperative evaluation, and in preoperative evaluation, we do chest X-ray, ECG, even if revised cardiac index is more, then we should do WICO2 or other evaluation should be done. Okay, no further testing should be done. So revised cardiac risk index, cardiovascular risk for non-cardiac surgery, it is high risk surgery, IHD, high risk surgery like vascular or intrathoracic high risk surgery, history of CHF, congestive heart failure, history of cerebrovascular disease, stroke TIA, history of stroke TIA, history of MI, history of heart failure, high risk of surgery, ischemic heart disease, diabetes mellitus, reducing insulin, and preoperative creatinine more than 2 milligram per dl. Risk of cardiac death on risk of cardiac death, non-fatal cardiac arrest or non-fatal MI. 0 to 1 factor, low risk, more than 2 factor, elevated risk. Elevated risk. So these 6 predictors should be uh, come in consideration and do as it said. Okay, this 1 hour old baby respiratory distress, 39 weeks of gestation, upper score is 5 and the 7 and 1 to 5 minutes now. Pulse is very high and respiration is slightly higher, not respiration is higher. Cardiac examination shows 3 by 6 ejection systolic murmur. Ejection systolic murmur. Physician examination otherwise Unremarkable bedside echo show increased thickness of the interventricular septal wall, increased thickness of the interventricular septal wall. So this is a diabetic mother, hyperglycemia in diabetic neonate, hyperglycemia in diabetic neonate, and so it's hypertrophic cardiomyopathy in infants and diabetic mother. Very confusing question. This newborn has mild respiratory distress and systolic ejection murmur with sonographic evidence by systolic ejection murmur. Systolic cardiac examination shows systolic ejection murmur. Systolic ejection murmur with sonographic evidence of interventricular septal wall thickening. We have just seen the pathophysiology, the interventricular septal wall thickening, glycogen and fat deposition in the interventricular septal, glycogen and fat deposition uh, in the interventricular septum, and dynamic ventricular outflow tract obstruction. It happens in the hypertrophic cardiomyopathy. Spontaneously regress by age 1. But this case, so we'll diagnose mild respiratory distress, systolic ejection murmur, consistent with hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. Infants of gestational diabetes are at risk of developing transient form of HCM. Exposure to excess glucose in the uterus leads to hyperglycemia, hyperinsulinemia, and increased fat and glycogen deposition. Increased fat and glycogen deposition that is more prominent in the interventricular septum cardiomyocyte causing HCM. Although most affected infants are asymptomatic, some develop heart failure due to severe left ventricular outflow tract obstruction, respiratory distress, hypertension, systolic ejection murmur. Other neonatal consequences for maternal diabetes. So hyperglycemia in first time it causes CNS, congenital left heart syndrome, and for neural tube defects S for spontaneous abortion and small left colon syndrome. And third and the fourth feature hyperglycemia and hyperinsulinemia. It may cause polycythemia, it may cause organomegaly, it may cause neonatal hypoglycemia. It may cause macrosomia, shoulder dystocia, increased glycogen synthesis, glycogen deposition in the interventricular septum, and increased glycogen deposition in the interventricular septum, which causes hypertrophic cardiomyopathy. Beta blocker reduce the heart rate, negative chronotropic effect, increase left ventricular diastolic volume, increase left ventricular diastolic volume, as well as end diastolic volume. So preloads increase left ventricular diastolic filling. Also, in addition, the negative chronotropic effect by beta blocker decreases the pressure gradient between the left ventricular outflow tract and outer, further reducing the left ventricular outflow tract obstruction. Treatment is rarely required for more than 1 week because insulin is very so insulin levels quickly normalizes and reduce to septal thickening and self resolution of the HCM. Okay, now a 1-day-old girl undergoes routine congenital heart disease screening in the newborn nursery. There is no cyanosis. Femoral brachial pulses 2 plus which of the following is the most likely cause of this? Mm, 40 weeks of gestation, the pregnancy and the delivery was uncomplicated. The patient stayed with her mother, breastfeeding, voided. Mm, okay, this is important. Like 99% solution, the right hand and 91 is right foot. So, uh, oxygen saturation difference between the arms and the legs looks like Mm, so in this condition, you need to persist the uh, persistent of the fetal circulation. It may be a transposition or persistent pulmonary hypertension of the newborn. So it is persistent pulmonary hypertension of the newborn. Sorry, I got wrong because it's the concept of discussing the mistakes. Because what happens to me, I made the same mistakes again and again. So what is the best way of ruling out your mistakes? Repeated practice, uh, repetition is the thing where you can decrease the mistakes. Okay, so oxygen saturation in the right hand is 99, 91 in the right foot. Looks like persistent pulmonary hypertension of the newborn. If I go through the box, there is abnormal persistent. There is abnormal persistence of the elevated pulmonary vascular resistance, right to left shunt across the ductus arteriosus, right to left shunt across the ductus arteriosus. Risk factor is lung hypoplasia. Risk factor is lung hypoplasia, congenital diaphragmatic hernia, lung hypoplasia, that is congenital diaphragmatic hernia, mass, meconium aspiration syndrome, and infection. Examination decrease postductal relative to preductal oxygen saturation. Decrease postductal decrease postductal relative to preductal oxygen saturation, and respiratory distress and cyanosis prominent S2. Oxygenation and the ventilation, inhaled nitric oxide, which is a pulmonary vasodilator. So these patients low postductal right foot saturation relative to preductal, right hand saturation consistent with right to left shunt, consistent with right to left shunt across the PTA. Right to left shunt across the PTA, because this patient has a strong distal pulses. Because this patient has a strong distal pulses, most likely there is persistent pulmonary hypertension of the newborn. At birth, physiologically elevated pulmonary vascular resistance normally decreases oxygenation and ventilation of the lungs. In persistent pulmonary hypertension of the newborn, also known as persistent fetal circulation, the PVR remains elevated. The pulmonary vascular resistance remains elevated. Deoxygenated blue blood cross from pulmonary artery into the aorta, mixes with oxygen. Blood pumped from the left ventricle, resulting in mm, relative lower postductal saturation, as there is admixture of oxygenated and deoxygenated blood. So when it goes to the foot, when it goes to the distals, so there is lower postductal saturation. Risk factor of persistent pulmonary hypertension of the newborn include conditions associated with lung hypoplasia like congenital diaphragmatic hernia, Potter sequence infection, pneumonia, meconium aspirant. However, some patients have no identifiable cause and simply have a slower decline in the pulmonary vascular resistance, resulting in mild to mild right to left shunt that can persist into the first few days of life, as it likely in these neonates. Okay, next question, how frequent headache with a relief, painkillers with a relief, blood pressure 185/100. There is a fourth heart sound. So S4, there is a continuous murmur noted throughout the thorax in the multiple areas, continuous. We know that continuous murmur can be PDA. There is fourth heart sound, age 34. Blood pressure is high, and there is a continuous murmur. Lungs are clear. There is frequent headache. So PDA can come alone. PDA can come with coarctation of the aorta. In coarctation of the aorta, patient can have PDA. So these patients most likely have coarctation of the aorta, usually congenital narrowing of the descending aorta, congenital narrowing of the descending aorta, typically congenital narrowing of the descending aorta, typically located just distal to the subclavian artery, typically located just distal to the subclavian artery. The narrowing creates proximal arterial pressure. That's why in the upper body, patient can typically asymptomatic hypertension. Hypertension of the upper extremity less often accompanying the epistaxis and headache. There is systolic murmur due to blood flow through a constricted aorta, heart at the left infraclavicular anteriorly and left interscapular area posteriorly. The murmur may be continuous if collateral vessels are present. A fourth heart sound due to hypertension-induced left ventricular hypertrophy may be present. Brachial femoral pulse delay, if measured, is typically present with diminished femoral pulse. In the majority of the patient, chest X-ray reveals notching of the posterior third and third to eighth ribs represents bone erosion due to enlarged intercostal arteries. The classic three sign is created by indentation of the aorta and pre and post stenotic dilatation. So coarctation of the aorta is narrowing of the descending aorta that leads to proximal arterial pressure. Patients typically have upper extremity weakness, diminished femoral pulse with brachial femoral delay. Chest X-ray demonstrate inferior notching of next. Okay, according to this question, this patient has hypertension, tachycardia, tachypnea, distant heart sound, JVB raise, looks like cardiac tamponade. In cardiac tamponade, right sided preload uh, is increased, left sided preload is also increased. That means um, right sided preload, right atrial pressure is increased, pulmonary capillary wedge pressure is increased, cardiac index is decreased, and systemic vascular resistance is increased. So looks like cardiac tamponade. So this is the answer, cardiac tamponades. We will go through the backstrat, and that's it. And okay, in obstructive shock due to this is the obstructive shock due to cardiac tamponade, that central venous pressure is increased, pulmonary capillary wedge pressure is increased, cardiac output is decreased, systemic vascular resistance is increased. Okay, in hypovolemic shock, what happens in the hypovolemic shock? Central venous pressure is decreased, pulmonary capillary wedge pressure is decreased, cardiac output is decreased, and systemic vascular resistance done by the arteriole is uh, is increased. Uh, in septic shock, or distributic shock, in septic shock, in septic shock, everything is going down. Like primary disturbance is the peripheral vasodilation. So central venous pressure is decreased, systemic vascular resistance is decreased, cardiac output is increased, and pulmonary capillary wedge pressure is decreased, so all decrease and cardiac output is increased in septic or obstructive shock. In septic or obstruct in septic shock. Okay, this is high output heart failure. In high output heart failure, central venous pressure is increased from the vena cava. Pulmonary capillary wedge pressure is increased from the pulmonary arteries, pulmonary veins. This is pulmonary capillary wedge pressure. Cardiac index, cardiac output is increased. High output cardiac failure, cardiac output is increased, and decreased SVR, decreased systemic vascular resistance, decreased SVR, that is AV fistula, arteriovenous fistula. So decreased SVR is arteriovenous fistula. So high output failure. So in high output failure, everything is increased and decreased systemic vascular resistance. Decreased systemic vascular resistance. Okay, got it. Next. So in this patient, what happens in pulmonary capillary wedge pressure is increased. So left-sided preload is increased. Cardiac index is decreased. In usually in cardiogenic shock, cardiac output is in cardiogenic shock. What happens in the cardiogenic shock? Right-sided preload, central venous pressure is increased, pulmonary capillary wedge pressure is increased, cardiac index is decreased, systemic vascular resistance is increased. So everything is increased except cardiac index. Oh, but in AV fistula, in high output failure, looks like cardiac. In here, central venous pressure is again increased, pulmonary capillary wedge pressure is again increased, but the cardiac output is increased. In cardiogenic shock, cardiac output is decreased, and systemic vascular resistance in high output failure is decreased. Got it. Next. So abstinence from alcohol, why it is not a C inhibitor? First of all, S3. S3 is a sign of heart failure. S3 gallop. This patient has low platelet, MCB high, but there is a high L thing in here. AST is higher than the LT. When there is AST is higher than the LT and gamma it is positive, looks like alcohol. So abstinence from alcohol actually, because his ejection fraction is very low, his heart, uh, his lungs are dying. His ejection fraction is low, so his hearts are dying down. So abstinence from alcohol, alcohol-induced cardiomyopathy. Okay, so it is alcohol-induced cardiomyopathy in AIC. Involves direct toxicity ethanols, though dyspnea, bivascular crackle, S3 and reduced left ventricular ejection fraction. Looks like decompensated heart failure. And the etiology is alcohol-induced cardiomyopathy. So this patient is near bipolar crackles, history, and reduced left ventricular ejection fraction are consistent with the compensated heart failure. This question, I don't know why I made mistakes. The low platelet, low platelet, neurological problem, heart problem, multiple sets of blood culture is dying, heart problem, neurological problem, low platelet, young woman, hematocrit count is also low. Looks like SLE, so non-bacterial thrombotic endocarditis is an option. So this patient has acute cerebellar infarction imbalance disease in the setting of small mitral valve density concerning for cardiometabolic risk, concerning for concerning for cardiometabolic risks. So it is concerning for cardiometabolic risk. So it may be non-bacterial thrombotic endocarditis or Lipman-Sachs endocarditis, which is associated with antiphospholipid antibody syndrome. The best next state age-appropriate cancer screening evaluation for hyperglycemia given these patients young age, thrombocytopenia, leukemia, anemia, resisting for antiphospholipid antibody syndrome. Next, ankle brachial index is low and on the left 1.1, on the right, so left ankle brachial index is low, peripheral valves are decreased by leg. So ankle brachial index for arterial disease, atorvastatin. So this patient with atorvastatin, aspirin, why we are giving aspirin? This patient has ankle brachial index in less than zero point 0.9, consistent peripheral arterial disease. Supervised graded exercise program should be done. Supervised cardiac examination should be done. PAD is or manifestation of atherosclerotic. PAD is manifestation of atherosclerotic cardiovascular disease. Statin reduces the reduce the risk of the cardiovascular index. So current guidelines recommend initiation of both low dose aspirin and statin for secondary prevention of all the patient with known case of ASCVD. In addition, PAD, another manifestation of ASCVD, myocardial infarction, stable angina coronary, is ended. Next, so it's stress induced ECG shows sinus dilated deep. She has undergone colonoscopy. After colonoscopy, there is ECG shows sinus tachycardia, deep symmetric, well, inversion V2 to V4. So this patient should have alternate form of contraceptive because 34-year woman BP is 145 by 90 to 150 by 95. Mm, Blood pressure measured during a health fair 2 weeks ago. She does not use alcohol or she does blood pressure 150 by 90. So she is on OCP. So first medication include OCP should be changed and look for hypertension is removing or not. So high fistula, what will you do in case of high fistula? In high fistula, cardiac output is increased, preload is increased, and after load is decreased. Okay, hemodialysis, enlarged vein. So, an arteriovenous fistula forms causes an hemodynamic changes because the fistula allows a portion of the blood bypasses the high resistance systemic arterial systemic vascular resistance is effectively decreased. Decreased preload. In addition, blood passing through the fistula returns to the right atrium more quickly. Decreased cardiac preload. Both the increased venous return, both the increased venous return and maintain. Okay, next. So this patient should be on clinical observation. After CABG, pleural effusion is more common. It is small to moderate size, early onset, not associated with respiratory problem. Just observe. If effusion do not meet the above criteria, should be actively investigated and treated for a complication like hemothorax, central line erosion, spatial mediastinitis, chylothorax, and this and that. Antiarrhythmic toxicity. This is very high level. 1 week he is instructed. Uh, so how will you diagnose an amiodarone toxicity? So clinical presentation: progressive dyspnea, non-productive cough, bilateral inspiratory crackle, amiodarone-induced pneumonitis, chest exercise, decreased local restrictive pattern. So pulmonary toxicity is a finding. Long-term amiodarone use can occur to several months to years after initiation interstitial pneumonitis due to amiodarone presence with progressive dyspnea. Amiodarone present progressive dyspnea. So the last but not the least, I will discuss the whole question. 65-year-old man comes to with known case of ischemic cardiomyopathy, comes to the office due to 2 weeks of progressive shortness of breath, non-productive cough. 1 week ago, he was instructed to increase the furosemide dose, but did not help him. He increased the furosemide dose, but it did not help him. You are giving furosemide and heart failure is not improving. Think about something. He has had no chest pain. He takes all the medication as directed at the corner, bilateral inspiratory crackle heart on auscultation. There are no cardiac murmur. There is no significant peripheral edema. Chest show bilateral lung infiltrate, palm to the involving primarily to the middle lung fills. And this is amiodarone toxicity. Amiodarone toxicity can cause cardiac problem like bradycardia, acute prolongation. It can cause pulmonary interstitial pneumonitis, organizing pneumonia, can cause hyper or hypothyroidism, hepatitis, corneal microdeposit, dermatological blue-gray skin discoloration, and it can cause peripheral neuropathy, neurologic peripheral neuropathy. So amyloid class 3, it can cause several potential risk factors, several monitoring should be done, organizing pneumonia respiratory distress can happen. Advanced heart failure is unlikely to explain because dyspnea with given that flat jugular vein, inhale flat jugular vein, absence of peripheral edema, and lack of improvement after doses JBP is flat line, JBP flat flat, JBP flat line, JBP is flat. Okay, okay, okay. So JBP is flat line when he is seated position. Respirator crackles. He has hmm, respirator crackle not improve with high dose flow. Some might think about something else. That's all for the Mystics series of cardiology. Hope you enjoyed.